So it's my great pleasure to introduce and ask Sripal Bangalore from New York to talk about evaluating cardiac injury following PCI. Welcome.
Thank you. Thank you, chairpersons, ladies and gentlemen.
So Dr. Bangalore is going to have to leave pretty soon after his presentation, so we'll take expanded question time, and clearly if we run out of time for the panel, that'll be how it plays out. Okay, so welcome.
Thank you. So what I'm going to discuss in the next few minutes is the universal definition of myocardial infarction, type 4A MI, which is MI associated with percutaneous coronary intervention. So what we are going to do is we're going to look at, there has been substantial changes between the second universal MI definition for periprocedural MI and also the third. So we kind of will look into the background and why there was a need for such a change. So in terms of mechanisms of periprocedural MI, there have been two different types of periprocedural MI which have been described. The type 1 is a proximal type of periprocedural MI, which is mainly due to side branch occlusion, and this could be an occlusion caused directly or indirectly during a coronary artery revascularization procedure. And type 2, which is more of a distal type, which is mainly due to distal embolization, which could be thrombus, plaque debris, or microparticles. And the mechanism of myocardial infarction in type 2 distal type of periprocedural MI could be one of many different reasons. It could be microvascular plugging, it could be platelet activation and neutrophil activation leading to inflammation and release of vasoactive mediators leading to vasoconstriction and hypoxia. And there is data to suggest that this is actually not falsely positive. In other words, the periprocedural rise in biomarker has been correlated with magnetic resonance hyperenhancement. And this has been seen both in the type 1 and type 2 kind of procedural MI. So if there is side branch compromise, there is MR enhancement in the adjacent regions. And if it is type 2, there is actually correlation with the distal enhancement. So in terms of impact of procedural CKMB elevation after MI, there has been a lot of data. I mean, this is back in the 90s from the EPIC trial where they looked at elevation of CKMB. And in patients with the normal CKMB, when compared to patients with several folds higher CKMB elevation after PCI, as we can see here, there is a direct correlation between the degree of elevation and also the estimated mortality rate up to 3 years follow-up. So because of all of these, this is an editorial written by Dr. Antman and Dr. Morrow. And if some of you have time, I think this is an excellent editorial. I would highly recommend this. So they have called this biomarker release after PCI to be a message from the heart. But of course, the periprocedural MI is extremely controversial. This is data from the BBC One trial where they reanalyzed their data based on two different definitions of procedural MI. If you use CKMB, the incidence of procedural MI was 7.4, but if you were to use troponins, now you suddenly see that the frequency of procedural MI is almost 5-folds. And this does have implications on the primary endpoint, as has been shown here. If you use the CKMB definition, the primary endpoint rate was 8% versus 15.2%, whereas if you use troponin definition, it's 32% versus 48%. And so these authors concluded by saying that incorporation of procedural MI into a composite endpoint may no longer be justified in many interventional trials. So, so the reason for the controversy is also we are not completely sure what causes this procedural CKMB elevation. And there is data, and as you heard from previous speakers, that the comorbidities might play a role. But in patients undergoing PCI, the baseline plaque burden can actually be a significant and independent predictor of CKMB elevation. And also, there is a relationship between procedural success and the outcomes in patients with an elevated CKMB. So this is a study which looked at patients after a PCI, categorizing them into no MI and various degrees of CKMB elevation after myocardial infarction and looking at their prognosis. And as we can see in the overall patient population, so you see that patients with no MI fared better than patients with any kind of procedural MI. But if you were to stratify this based on procedural success rate, so in patients who did not have a successful procedure, you see that the biomarker elevation is significantly higher and the prognosis is much worse. But if you look at patients with a successful procedure, you see that the elevation in CK was not prognostically significant. So there is a controversy as to how to interpret CKMB elevation after PCI. So there have been a lot of advances in biomarkers for myocardial damage, moving from CPK to CKMB to troponin to high sensitivity assays of troponin, and we also moved from enzymatic assays to immunoassay. All of these translates to detection of progressively smaller concentration of cardiac troponins in the peripheral circulation. So this has a direct implication on the frequency of procedural MI, because this does vary with the biomarker used. So this is data from the event registry in 4,900 patients undergoing elective PCI. And if you were to use CKMB as the marker, the procedural MI rate was 7.2. And if you were to use troponins, this is actually increased threefolds, 24% procedural MI rate. So this is data from all of the studies. I mean, this is a meta-analysis of studies looking at the frequency of procedural MI if you were to use CKMB in red and troponin. And as we can see, the rate of procedural MI actually varies pretty significantly, and this is consistently higher if troponin is used. So it's more sensitive, and you see, and in at least few of the studies, nearly half of the patient actually could have been diagnosed with a procedural MI if you were to use troponins. So we discussed a lot about increasing sensitivity of troponins. I mean, this is data from many different studies looking at marathon runners and the incidence of troponins, which is actually higher than the AMI threshold. And as we can see here in some of the studies, at least 51% of marathon runners had detectable troponins, which actually exceeded the AMI threshold. This gets complicated if you were to use high sensitivity troponins. So this is data from 85 marathon runners. If you use cardiac troponin T, the incidence of people where the troponin exceeded the 99th percentile upper limit of normal was 45%, but with the high sensitivity troponins, almost all of these had some detectable high sensitivity troponin numbers. So this does have implications. So if you have a patient post PCI, so based on the biomarker used, the patient may or may not have a pre-procedural MI. And this has a significant impact on how to interpret clinical trials. And if you take an example of stent versus stent trials, stent A versus stent B, and if the frequency of procedural MI is similar between the two treatment groups, stent A and stent B, the frequency might change if you use CKMB versus cardiac troponin versus high sensitivity troponins, but the relative difference will probably be the same. But the problem becomes if the two treatment strategy have differential incidence of procedural MI, such as trials comparing PCI versus optimal medical therapy. So in such trials, the frequency of procedural MI can actually play a significant role in the interpretation of these trials, as we'll see in the next few slides. So given the frequency of these procedural MIs ranging from less than 10% to approximately 50%, this will likely drive the primary results of the trial. So there is also controversy about what should be the biomarker threshold for prognostically significant MI. And this is data from the SPIRIT trial looking at the frequency of MI based on different biomarkers. So if you look at the protocol-defined MI, the frequency is 1.6%. If you were to use CKMB, it was 5.4%. And if you were to use troponin, it was 18.7%. At least in this study, there was no association between procedural MI and mortality up to 2 years by either of these definitions. But other studies have looked at a similar question, and they have shown that probably you need a higher threshold of biomarker threshold for prognostically significant MI. This is data from the event registry, and the risk of adjusted 1-year mortality according to post-PCI CKMB elevation. And we see that for CKMB greater than or equal to 50, this was associated with a significant increase in the risk of 1-year mortality. So this becomes problematic when you want to look at troponins. And here, if you use the same cutoff, so and this is data from the event registry. These lines represents no MI. This is for troponin MI, and this is for CKMB MI. And what the study found was the mortality effect of greater than 3 times, threefold increase was much greater for CKMB than for troponins. So if you look at the absolute attributable hazard ratio, it was 2.5 for CKMB. It was only 1.7 for troponins. And what this study found was a troponin threshold greater than 20 times the diagnostic level provided similar frequency and mortality risk as a threefold increase in CKMB. In other words, a threefold CKMB will not equate to a threefold increase in troponins. So what is the prognostic value of a procedure versus a spontaneous MI? And to my mind, the question is not whether procedural MI has prognostic significance. I mean, I would say that the procedural MI is definitely of prognostic significance. But the question really should be whether procedural MI has similar prognostic significance as that of spontaneous MI. And this is specifically relevant to clinical trials where we use both a composite of procedural and spontaneous MI. This has been assessed in many studies. So this is data from 11 PCI clinical trials where they looked at the prognostic value of no periprocedural MI versus periprocedural MI in red. And what was seen is in the unadjusted analysis, patients with procedural MI definitely had a higher rate of mortality when compared to patients without a procedural MI. But in the adjusted analysis, you see that this kind of difference actually disappears, and this is for 3-year overall mortality. And if you look at procedural MI versus spontaneous MI had much more higher risk of future mortality when compared to procedural MI. We looked at some of this data, looking at the event registry to to evaluate the relationship between procedure versus spontaneous myocardial infarction, and we found something very interesting. So in patients presenting with a spontaneous MI, these are patients who actually presented with a larger level of troponin elevation. So many of them had a troponin elevation more than 10 times the upper limit of normal. But if you look at patients presenting with patients who had a procedural MI, these tended to be somewhere in the intermediate range. So if you were to equate both procedural and spontaneous MI, this becomes problematic because the degree of elevation is definitely different between the two groups. So in terms of the prognostic significance, in terms of 1-year all-cause mortality, there was a graded relationship between patients without an MI, those with procedural MI, and those with spontaneous MI. But in an adjusted model, we found that spontaneous but not procedural MI was independently associated with death and cardiovascular death at 1 year. And we concluded by stating that these findings suggest that the prognostic impact of procedural MI may be less than that of spontaneous MI, and should be considered in designing endpoints for future studies of coronary revascularization. And if you look at clinical trials and procedural MI, so this is data from COURAGE trial, and as I hinted before, so this is of more significance when there is a differential incidence of procedural MI between the two groups. COURAGE trial, 2,200 patients randomized to PCI and OMT. If you look at all non-fatal MI, which actually was a composite which included both procedural and spontaneous MI, there's no difference between PCI and OMT therapy. But if you look at the components, there was a significant increase in procedural MI with PCI, which is a no-brainer, and there was no difference in spontaneous MI between the two groups. But if you look at all-cause mortality and cardiovascular mortality, we see that this is an indirect comparison, but we see that the procedural MI does not track for the point estimates for all-cause mortality, but the spontaneous MI kind of tracks with all-cause mortality and cardiovascular mortality. Interestingly, we see similar relationship with many other trials. This is FAME2 trial, patients randomized to PCI versus OMT. Again, no difference in non-fatal MI between the two groups. Again, significant increase in procedural MI with PCI, but there is no difference in spontaneous MI between the two groups. And if you look at all-cause mortality, it seemed to track with the spontaneous MI and not actually with procedural MI. We actually looked at all of the randomized trials, 12 randomized trials, 37,000 patient years of follow-up, looking at PCI versus medical therapy from randomized trials. and we found that there was no difference between PCI versus OMT for non-fatal MI. But of course, there was a significant difference. So PCI actually resulted in significant increase in procedural MI, but at the same time, there was a significant reduction in spontaneous MI with PCI compared to OMT. In the end, these two canceled each other, and of course, we had a null effect. But of course, when you look at the signal for all-cause mortality and cardiovascular mortality, we again see that it's spontaneous MI which tracks for all-cause mortality and not procedural MI. So the other problem we face in terms of procedural MI is this data. So if you look at practice patterns across the United States, only 7% of patients undergoing PCI as post-procedural CKMB levels measured. So I can tell you I practice in New York City, and of course we do not draw routine procedural routine biomarkers in our patients undergoing elective PCI. And the other big problem is there is a push towards same-day PCIs and to discharge these patients on the same day, so makes it all the more difficult to draw these enzymes. So let's look at some of the definitions. So this is the second universal MI definition. So periprocedural MI was defined as elevation of cardio biomarkers greater than 3 times 99th percentile of the upper limit of reference. And there was a preference for troponin. And so this is 2007. And in 2012, of course, we have the third universal MI definition. And as I showed you all of the data before, this is a challenging field. I mean, it's very difficult to figure out what is a prognostically important procedural MI. So here the definition is elevation. Now the troponin threshold is greater than 5 times 99th percentile. But you also need one other marker. So in other words, there is a move towards more specificity. And this one other marker could be symptoms. It could be ischemic EKG changes. It could be angiographic procedural complication, or imaging evidence of new loss of viable myocardium. The problem with this, I mean, I like the direction it's taking. I mean, there is more move towards more specificity. But the problem, as acknowledged by both these documents, are these are all arbitrary and it's not completely based on evidence. Now let's look at a few other definitions. The Society for Cardiovascular Angiography and Intervention came up with a clinically relevant MI definition. And of course, the definition, as you see here, again, there is a move towards increasing threshold. So the MB threshold is greater than or equal to 10 times. But if it is greater than 5 times, you need one other marker, which is EKG changes of Q waves or left bundle branch block. And in the SCAI definition, if you were to use troponins, now you see that you need a 70-folds increase in the biomarker. And if it is 35-fold increase, you need one other EKG changes to corroborate with your findings. So we are doing the ischemia trial, which is a large randomized trial of invasive strategy with PCI or CABG versus a conservative strategy of optimal medical therapy alone. So we've had a lot of discussion, and Dr. White has been part of some of this discussion. And this is the definition we came up for the ischemia trial. So it's MB greater than 5 times upper reference limit plus one of the following angiographic complication or EKG changes. If you were to use troponins, it has to be almost a 7-fold difference. So it's an increase in 35 times the upper reference limit plus one of the other complications. And if it is just a biomarker threshold, it's MB greater than 10 times and troponin greater than 70 folds. So the universal MI definition actually, the universal MI definition recommends 99th percentile to use as a threshold. So we actually looked at, in the ischemia trial, we reached out to all of the sites to actually obtain the 99th percentile values for each of the sites, and also their the hospital troponin MI decision levels. And this is some of the data. I mean, we presented this yesterday. What we found was, in majority of sites, there is a vast discordance between the 99th percentile and actually the MI decision levels. In some of the sites, actually, there is a 10-fold increase between the 99th percentile and the MI decision threshold. And the data indicates this is data from close to 200 sites, that only 1/3 of the labs actually follow the third universal definition of MI threshold for detection of myocardial infarction. So in conclusion, the frequency of procedural MI varies considerably based on the definition from less than 10% to greater than 50%. This definitely has implications for clinical trials, especially in trials with differential frequency of PCI in the 2 arms. And procedural MI is not infrequently used in the component outcome definition of clinical trials and has the potential to drive the results based on the definition. So, and in many of the trials, procedural MI has been given the same weightage as spontaneous MI in clinical trials. And of course, there is controversy over the prognostic value of procedural MI, with more recent studies showing that spontaneous but not procedural MI may be prognostically important. The flip side of the story is, of course, we are not doing routine biomarker testing post PCI in the United States, and this definitely has implication for clinical trial results, because if clinical trial results are mainly based off of difference in procedural MI, you're not going to see that in clinical practice if you're not even drawing those biomarkers. The revised procedural MI definition, such as the universal MI definition and the SCAI definition, likely have more specificity, but we definitely need more studies to test the prognostic value of these definitions. Thank you for your attention.
Thank you very much, Joe Alpert.
Well, Dr. Bangalore, you have in fact identified the most difficult problem that the task force had, because there is no gold standard in these individuals. The injuries are very small frequently, as you've shown. But we have discussed this extensively in the task force, and we're fearful that CKMB is not going to be the right biomarker, because whatever variation you saw for troponin, it's multiple times higher for the CKMB assays. They are much less standardized. And really, you know, the problem here is calling these things a myocardial infarct. Right. Because when we call it a myocardial infarct, everybody runs for the hills in terror. Oh my goodness, you did something to me and you caused me to have a heart attack. And that's why in the last definition we started moving away, at least for the smaller injuries, from calling it myocardial infarction, but calling it myocardial injury. And yesterday in the task force meeting, you know, for the next go-around, we actually began discussing about calling all of these not myocardial infarct, but procedurally related myocardial injury. At least that takes away some of the terror in the term. And as you point out, the pathophysiology is completely different. These are small injuries. And of course, it's not surprising that they have a better prognosis than as Peter referred to as the wild type MI, because in fact the patient leaves the lab with an open coronary. So you'd expect them to have a better outlook than the patient with the wild type, who may still have an occluded coronary. So we're wrestling with this. It would be wonderful if we had a gold standard. For example, we had a super sensitive MRI where we could compare actually the quantity of necrosed myocardium to the elevation in the biomarker. But as you know, the MRI only picks up substantially larger injuries. So that has led to, as you know, the first definition in 2000, we said any elevation in troponin was an MI. Then we went to 3 times without clinical information. Then we went to 5 times with clinical information. I don't know where we'll be the next time, but we're basing it on our evaluation of the literature with respect to prognosis. And I think, as I've said, we're moving away from calling this MI, because I think that's what terrorizes everybody. And absolutely in the clinical trials, these should be under separate categories. And even from the very first paper, we suggested having a table with the biomarker level, the numbers, so people could actually work with those kinds of numbers.
So those are all excellent points, and I can tell you that we have struggled with this concept even in the ischemia trial. So we are actually going to present all of the MI definition. It's going to be universal MI definition, and if there is any other definition that comes along the way, so we are going to present it in every possible way so that every stakeholder can take a look at it and make their determination.
Dr. Jeff.
One of the precepts of the universal definition MI diagnosis is that you have a normal baseline. Terribly important, because if the baseline is rising, the ability to distinguish the types of injury is problematic. And even in the more chronic circumstance, there's a relationship between the elevation or the degree of elevation and the extent of and complexity of the coronary disease. And as you've shown, throughout the United States, people use different quote-unquote normal values. Mm-hmm. And no definition will work if one utilizes a heterogeneity of baseline values. So that whether you agree or disagree with the use of the 99th percentile, if indeed it's not used at baseline, you're guaranteed to have tremendous heterogeneity. More importantly, in many studies, not all, but almost all of the ones that have really used the 99th percentile, when one adds that to the prognostic evaluation, most of the prognostic sensitivity of the post-PCI elevations is ablated totally. And there are two important reasons that I think we ought to understand that. Number one is it suggests that it's not the PCI that's harmful. And I'm not an interventional cardiologist, all right? But I defend them in this regard because I don't think it's the PCI that does it. It reflects really the complexity of the underlying disease. And we struggle with what's a prognostically significant PCI value. But in point of fact, if you think about it, it's very much like the spontaneous MI. Small amount of damage in a person with a very damaged ventricle is something very different than a large amount of damage in somebody who has no other risk factors and is having a first small event. So I do think emphasizing the need to get the baseline right for everybody is terribly important, or if we're ever going to make sense out of the field.
It was a long question. Could you make it short?
Thank you for those excellent comments. So I can tell you, I mean, in the ischemia trial, we're taking great pains even to get we are getting baseline biomarkers in all of these patients, just for exactly the reason you alluded to.
Thank you very much.
Thank you.
And now we'll move along.